Yes, ma'am.
How do you feel about dropping our lowest quiz scores?
How do I feel about that? I don't feel anything about that. I think it might be a good idea if we have enough quizzes.
Oh, yeah. Dr. Reed, did you like put due dates on the McGraw-Hill thing?
Yeah.
Because there's, yeah, like the unit, 6 test is like before the unit 4 and 5 one.
There's like there's probably like 10 due, like May 14th.
And then there's like.
Oh, did they not take? Because I redid all those last week.
Yeah, that's the chapter. And then there's like chapter 4 and Mark 1. I didn't know if like.
So 4 is still May 14th or?
Chapter 4 is due March 1, but then chapter 6 is due February 24th. I didn't know that was.
Yeah, 4 is a pebble in my shoe that won't go away. I redid it and it's still, for some reason, the questions I put, new ones popped up. It's very strange. So 2 looks like it's fairly well behaved. Yeah, I can't figure out what's up with that. And I asked the tech people at McGraw-Hill, I even showed them your picture, and their answer was, say what? Which I said, she ain't lying. She ain't seeing things. It's right here. They said, well, I can't do this. We ain't never seen that before. Well, gang, that doesn't help me a lot, so. I got interviewed by the school newspaper about the vaccine. Yep. Told them the vaccine's safe and efficient and everyone should get vaccinated. That's what I told them. Well, it was longer than that, but that was the main thrust, and that this mythology that it makes you sterile is just that, mythology. And that it kills you, makes you die, that's mythology too. So. Because you're more immune to the antigens and your body thinks you're sick. And now you're actually sensitized to the antigens, so your body goes for it. And so you release lots of IL-1, lots of IL-6, lots of IL-12, and you feel like crap.
Why do some people react and some people don't?
Probably because of the nature of the immune response. Every time you give someone a vaccine, the immune response you get varies from person to person. Young people get worse side effects than older people because young people's immune systems are more robust than older people. And even among younger people, responses vary. So there's a retired missionary he taught over J-term. I don't know if he's teaching now. Clint Smith. Clint got the Shingrix vaccine about the same time I did. Clint was in bed with a fever the next day. I felt like crud, but I got over it in 4 hours. So it's just very individual. Still can't feel my hands. It is so cold out there. Okay. Sorry, no treats tonight. Now that really tears you all up, but Don't thank me yet. Yeah, one that's all yours. Oh, genetics. I taught that last year. Oops, sorry. Yeah, I think you're supposed to open that before you drink it. Right? Yeah, I got that right. Yeah, okay.
Thank you.
Those of you on Zoom, I sent you a chat. Go ahead and respond to the chat. Yeah. Well, but should it be considered if all the topical stuff fails? No, there's consideration. I mean, if the patient's a male, obviously not, but is that an option if topical treatments fail? That's getting at. Okay, works for me. Okay. Very cool. Thank you. Okay. Cheers. Thank you, Abby. No, I don't think you did either. All set? Good? Yeah. Allison, you done? Right, cheers. Doris, you done? Okay. Oh, okay. Let's see, you're done. Yes, sir. Okay, good. Very good. Great. And all done, Paige? Okay. Very cool. Thank you. Okay. Oh, good glory, that's false kilter, isn't it? Let's get you fixed. Oh, much better. All righty. We ended up last time looking at treatments for head lice infestations. And I believe we ended with malathion. Is that correct? Yeah, okay. And so to reiterate about malathion, malathion is very safe. When I was a kid, we used to use malathion on my dad's grapes. And there was a person, their name escapes me, but they went on and on and on and on about how unsafe malathion was. And the USDA official, in order to show this person that it was baloney, went to the table and mixed up some malathion and drank it. And proceeded to say that it tasted really awful, but he had no ill effects from the malathion. And that, in fact, is the case, that malathion is quite safe. You can drink it, essentially, and it won't hurt you. So malathion is very useful. You apply it to hair that's dry, and then you leave it in. The funny thing is that experiments have shown that you can apply it for 20 minutes and then wash it out, and it works for half a day. It is flammable and it doesn't smell very nice. But it is safe during pregnancy. Some people get a stinging sensation when it goes on. That's not all that common. Chemical burns have been reported. That's not very common either. It is usually quite safe, but you need to get this by prescription. And the product is called Ovid. Ovid. Next product is benzyl alcohol. Benzyl alcohol. This just kills the adults, does not kill the eggs. So it's 5% lotion. You apply to dry hair for about 10 minutes. You rinse it out. You then repeat 7 days later. If you get it in your eyes, it will cause eye irritation, redness, hyperemia of the eye. It is safe during pregnancy. If you have a really heavy infestation, you'll need to reapply it. If you have a light infestation, it will tend to kill all the adults. Since it doesn't kill the eggs, you tend to want to use this with a knit comb. The kits come with a little knit comb. You ever seen those knit combs? Then if somebody has really fine hair, combing it out with a knit comb can be a genuine pain in the wazoo. But that will get the eggs. Someone who has coarser hair, it's much easier, usually. So knit combs, if you have really fine hair, they can be a little harder. All right. Spinosad. Spinosad is a drug that will, chemical that'll kill both adults and eggs. You again apply it to dry hair for 10 minutes, then you rinse it. Retreatment is usually not necessary. It's very effective treatment. You actually suspend it in benzyl alcohol. And if it gets in your eyes, it can burn your eyes. There's been reports of redness and irritation of the scalp. That's not very common. It's also safe during pregnancy. Spinosad is probably your go-to in a lot of cases. Then finally, there's ivermectin. Now, ivermectin is normally a worm drug, but it can kill lice. It comes in a topical and an oral formulation. The oral formulation is very cheap. The topical is not. So you apply it to the hair and scalp for 10 minutes, then you wash it out. It's not ovicidal, but it has very good residual effects. So anybody that hatches after 48 hours is kaput. This drug will inhibit glutamate receptors. So your ligand-gated channels for chloride that are glutamate linked, this will block those channels. Resistance has not been reported. If it gets in your eyes, it can cause eye trouble, dry skin, sometimes a burning sensation. The oral ivermectin is not safe during pregnancy. Virtually all the others are. Oral ivermectin is well tolerated. Some people get diarrhea. You take one dose then you repeat after a week. It's very cheap. Your book mentions Lindane. Don't use Lindane. Doesn't work. Lindane also, especially in children, can cause, very young children, can cause neurological issues. I don't know why they listed Lindane. They're much better agents. Don't use Lindane. Don't. Ivermectin also can be used to treat scabies. So scabies is caused by mites, thrombiculid mites that burrow into the skin. And as they burrow through the skin, they cause a lot of redness and they can itch like nobody's business. So this stuff, Glutamaton, is a very good topical agent that's used for scabies that will, it's quite safe. And that's a good one. And so ivermectin is used as well. Again, you can't use ivermectin on someone who's pregnant. Definitely not safe. Okay. Any questions about any of those compounds? Again, if you work family medicine, peds, schools, you'll see head lice. Trust me. Trust me. It's actually quite common. And now we need to talk about antibiotics for skin and skin structure infections. And that leads us to circle back to chapter 7 for a look at antibiotics. So let's talk, since we're talking about skin, we'll go ahead and talk about the ones used for skin first, then we'll just talk about the antibiotic in general. All right. Now, if you have a deep infection that are caused by staphylococcus, and particularly if the agent is methicillin resistant Staph aureus, then usually you need to go to the glycopeptides. And does anybody remember what the drug of choice of the glycopeptides is for MRSA? Can you speak up, please, a bit? Vancomycin, exactly right. Vancomycin. So, vancomycin comes usually in a bag and it's administered intravenously. There is this massive histamine release you can get with vancomycin, leading to so-called red man syndrome. That's something to watch for. What are you going to watch to see if they are getting red man syndrome? Watch your face. That's usually what turns red first is their face. So watch your face. If someone has had red man syndrome, then you pre-treat with antihistamines. The other trick you could use for red man syndrome is infuse the vancomycin in more slowly. So typically you infuse vancomycin in about 30 minutes. You can slow that down, make it an hour. That may tend to prevent red man syndrome. In fact, all the glycopeptides can cause red man syndrome. And if somebody is prone to it, you can just slow down the infusion. That'll tend to decrease the risk of it. Or you can load them up with antihistamines. That works too. All right, so this is your drug of choice. Big thing you're going to watch with vancomycin is for renal toxicity. In people with healthy kidneys, it's not that much of a problem usually, but if their kidneys are not working as well as they once did, then you might see a drop in renal function. That drop may not be permanent, but you do want to watch renal function. Okay, there are some other options for the glycopeptides. All of these are given intravenously. None of them are given orally. So there's dabivancin. Dabivancin is also used for MRSA. And this one, you give this essentially over a week usually. And again, you infuse this over about 30 minutes, but you slow it down if there's red man syndrome occurs. Then there's ortavancin. That's another one of these glycopeptides. And then there's telavancin. So with telavancin, this can increase your INR. What's the INR? You have to speak up. I'm sorry, you have to speak up. I can't hear you if you mumble. Please speak up. International normalized ratio. International normalized ratio for what? For how long it takes your blood to clot. Why do you use an international normalized ratio? Because different labs come up with different numbers for the same blood. Why? Because you use different reagents. So you go to the web, you look up your reagent, and it standardizes essentially the number you get for the lab to a standardized scale. That's why you get an INR. What should an INR be for a normal person? Anybody know? Close to 1, 0.9. 0.9. 0.9 to about 1.1. So 1 would be right in the sweet spot. So yeah. And ortavancin can also increase the INR as well. So with these two, you don't give these with unfractionated heparin. And heparin's used a lot in hospitals. I'm sure you guys have come across heparin. Very, very popularly used anticoagulant. Ortavancin, not approved for pediatric use. Telavancin, not approved for pediatric use. Davavancin, not approved for pediatric use. Vancomycin is approved for pediatric use. And telavancin can also be nephrotoxic as well. Davavancin or Davavancin don't seem to be as nephrotoxic. All right. Any questions about these? Again, these are parenteral. You have to give these with a needle. Yes, Emily. So heparin is a complex polypeptide, and it's an animal product. And so the length of the carbohydrate varies in heparin. And so if heparin is unfractionated, it means you have a heterogeneous product. Low molecular weight heparin is a synthetic product where all the heparin chains are the same length. No, because low molecular weight heparin, the product is homogeneous. You absolutely know the half-life. With unfractionated heparin, you have a range of half-lives. Also, low molecular weight heparin just inhibits factor 10, whereas the unfractionated heparin inhibits thrombin because it activates antithrombin 3, the antithrombin 3 protein, which binds to thrombin and inhibits it. We'll get to that when we talk about anticoagulants. If someone gets a knee replacement, I think maybe even probably a hip replacement, they get sent home with low molecular weight heparin, and they're supposed to give themselves sub-Q injections once a day, I think it is. Something like that, once a day, because the surgery itself puts you at risk for a clot. And you stay on that for a week, I think. I'm not a surgeon. I think it's a week. And if any of you have had family members who've had hip or knee replacements, you've probably seen the little box with the little bottles of low molecular weight heparin. Lovenox, it's called Lovenox. It's called enoxaparin. You guys are looking at me like I'm from Mars. You haven't seen it before? You will. You'll see a lot of it in the hospital. Yeah. No, heparin is not given orally. No, heparin is always given parenterally. There are oral anticoagulants, yes, but you don't tend to use those after orthopedic surgery. Heparin is much more reliable and causes much less bleeding than an oral anticoagulant. Now, if they have atrial fibrillation or something like that, yeah, then they need to be on an oral anticoagulant, but not if they've had an orthopedic procedure. Now, if they develop a clot later on, yeah, then they go on an oral anticoagulant, but most don't. Most don't. Okay. Now, since we're talking about parenteral drugs, let's talk about some of the other parenteral drugs you can use for deep skin infections. So these would be used for things like cellulitis, maybe things like erysipelas. If you have a burn patient with a staph infection and MRSA is the issue, then you'd use these. If you have a patient with maybe it's a surgical infection, abscess, something like that, and it's MRSA, these are the ones you'll turn to. If you have a agent that's resistant to vancomycin, you can try these others. So that essentially increases your armamentarium against MRSA. Now, I think what you might, Emily, be getting at, tell me if I'm wrong, there is an oral version of vancomycin that's used to treat Clostridium difficile infections. That's what you're thinking of, or maybe? Okay. There is an oral form, and that's used for Clostridium difficile infections. Grace?
So all four of those, sample and then the other two, they can also work with?
Yeah. All of these are anti-MRSA. They don't work against gram-negative bacteria. They're too big. They can't penetrate the outer membrane. So these are gram-positive only. So you might also use these. In fact, Grace, if you work cardio, you get a patient with endocarditis, you might use these as well because they penetrate heart muscle pretty well. Okay. Now these, the oxazolidones, they come in an oral and a parenteral form. So these, while these are just parenteral, you know what I mean when I say parenteral, right? Good. Okay, good. Some of you are looking at me, giving me a funny look. Okay, I look funny, I know that, but just you don't know if there's a buzzword, you don't know what it means, just raise your hand and say, what's that buzzword mean? There's no shame in that, really. The amount of words you guys need to know, if you forget one for a little bit, that's fine. This is a no judgment zone, except when you take quizzes. Other than that, it's a no judgment zone. Okay, just like Planet Fitness. Okay, so linezolid, again, this comes in an oral form, but it also comes in a parenteral form. This, again, is a specialist for gram-positive bacteria. It's not effective against gram-negatives. But since many skin infections are caused by gram-positive bacteria, that's a good thing. This is an alternative for MRSA infections of skin and soft tissue, particularly in hospitalized patients. That's why the parenteral form is used for hospitalized patients. For outpatients, you'd use the oral form. Now, the biggie with this drug is you don't want to use it more than 14 days. Yes, Morgan. This is the class. This is the class. These are the members of that class. This is the class. There's 2 members of this class. So this drug, if you give it for more than about 14 days, it'll cause bone marrow suppression. In fact, even if you give it for 7 to 10 days, some patients will show bone marrow suppression. So what are you going to watch for bone marrow suppression? Ooh, what? What, Grace, what did you say? You take it back. In sackcloth and ashes, okay. Yeah, CBC, right, CBC. That is fast, it's easy, it's not expensive. CBC, essentially, if the bone marrow is starting to be suppressed, you're going to start to see some leukopenias, thrombocytopenias, you're going to see some anemia. And if bone marrow is suppressed, it'll happen usually to all the cell types in the blood. You'll start to see low counts. Counts will be pretty universally low. You don't need to do a bone marrow biopsy or something. No. CBC, that's all I need to do. Draw some peripheral blood, do CBC. Easy, easy. Now the biggie in particular is thrombocytopenia. That's one of the, with the bone marrow suppression, the cell type that suffers the most are the platelets. So thrombocytopenia is usually the first sign that you'll see that bone marrow suppression is happening. And if that's the case, you need to tell the provider. they need to get off this drug ASAP. Yeah, it will. It will usually if you withdraw it. It won't go up right away, but it will go up. Yeah. These are for skin infections in general. Now, the other thing about linezolid, it is a monoamine oxygenase inhibitor. That means if you give this drug with serotonergic agents, you can cause serotonin syndrome. This is a weak monoamine oxidase inhibitor. What's monoamine oxidase do? Yeah, for depression. They're not used that much anymore. They've got a lot of side effects. Although some psychiatrists are convinced that MAOIs are actually pretty good drugs and have been given a bad rap. My view is that they're better drugs for depression. You should only turn MAOIs if nothing else works. But, you know, nobody cares what I think. So because this is a weak monoamine oxidase inhibitor, if you give it, and since monoamine oxidase is used to inactivate serotonin, if you give it with a serotonergic agent, you're going to overdose on serotonin. And that's going to cause serotonin syndrome.
So it's like a dual purpose drug almost like
Well, it's that's just a incidental feature of the drug. Yeah, Paige, you had a question? I answered your question. Yeah. No, it's not used for depression or something like that. Well, there never was.
oh,
That's an incidental, just like some cephalosporins. Some cephalosporins also interfere with blood clotting. Were they designed for that? No, it's incidental. Yeah, Grace?
what's the syndrome called again?
Serotonin syndrome. Serotonin syndrome. You've probably heard that in med-surg. Not yet. You will. You will. The patient can fall into a coma. It can be scarier than heck. Clarissa? SSRI or an SNRI or even some tricyclic antidepressants, because some of those have serotonergic activity. Or some dual drugs like bupropion, that'll do it too. So you have to be really careful what the patient's on. Your brain essentially gets hyped up on serotonin. Serotonin floods the brain, and the patient gets very groggy, and they may lose consciousness. It's very scary. And the thing about serotonin syndrome, can't really give them anything for it. You have to wait until the serotonin levels just have to wait and watch, and you feel helpless, and yeah. So don't go there. Don't go there. There are lots of combos that'll do that. It's you give an MAOI, say with Demerol, that'll do it too. There's combinations of drugs that'll do that, and usually the drugs that do that on the insert, there are warnings. They're not black box warnings, but don't give with for risk of serotonin syndrome and so on and so forth. Now, there's a new member of this group called telazolid. And telazolid, I'm running out of room. Telazolid also comes in a parenteral and an oral form. This drug is also effective against susceptible gram-positive bacteria, but this is less likely to cause bone marrow suppression than linezolid. And it's a reversible inhibitor of monoamine oxidase. So it's less likely to cause serotonin syndrome than linezolid. So some physicians think this might very well end up replacing linezolid, tedazolid. So it's a rather new drug. Yeah, Abby? Yeah. Yeah. You get a twofer with this one. Yeah, Grace?
So the linezolid is currently the first line of,
Yeah. Yeah. Tedazolid is very new. It's very new. City?
how do we know that it is less likely to cause?
Because of the clinical trials. In the clinical trials because in the clinical trials it was compared with linezolid to make sure it was not inferior to linezolid. In the clinical trials it was shown to be non-inferior to linezolid, but it didn't have nearly the tendency to cause bone marrow suppression. And when combined with serotonergic drugs, because it's a reversible, that was done in animals, of course, because it's a reversible inhibitor of monoamine oxidase, its tendency to cause serotonin syndrome was much lower. Paige? What kind of skin infections would you use these? They'd be an alternative to vancomycin. Let's say your agent is resistant enough to vancomycin, so you have to really jack up the concentration, but their kidneys won't take it. Then you turn to something like this, or something like those, or what have you. Yes. Because it's cheaper. This is new, so it's really expensive. Still under patent. And the drug company, it's expensive to develop these. Drug companies trying to recoup their costs because it's probably close to $1 billion invested in making that drug. So those darn drug companies, without them, we wouldn't have the drugs. So, shut up and take your medicine. Morgan?
So are these classified as antibiotics?
Yes, they're antibiotics. They are antibiotics. We are talking about antibiotics. Now, there is also a 5th generation cephalosporin that we actually talked about last semester, but I'll remind you of it. And that is ceftaroline. And ceftaroline is active against MRSA. So this is a 5th generation cephalosporin. It is a different class. This one cannot be taken orally. This is only available parenterally. So this one too is a drug that is effective against methicillin-resistant Staph aureus. Now, if you're still essentially in deep weeds and you need another agent that you need to use, there is also daptomycin. Daptomycin. Incidentally, the trade name of this is Taflaro. Taflaro, that's the trade name of that. Yes. For ceftaroline. I drew a line there to try to separate the two. Daptomycin is called Cubicin. No, it's different. It's completely different. So this is a so-called lipopeptide. This is the only member of its class. And it is a specialist against gram-positive bacteria. You give it parenterally. You have to adjust for renal function. You cannot give it in an inhaled form because lung surfactant inactivates it. Now, the biggie with this one you need to watch for is that you see an increase in phosphocreatine kinase levels. Phosphocreatine kinase, or creatine phosphokinase, what's that an indicator of? Cubicin is a trade name, yeah. That's a generic, that's a trade name. This one's still under patent, so you'll see it in the pharmacy under the trade name Cubicin. This means you're getting muscle damage. Myopathy. So you want to look in the blood for phosphocreatine kinase levels. Yeah.
How is that different than
It phosphorylates creatine, but because the reaction can go in both directions and it makes phosphocreatine, it's called phosphocreatine kinase, or sometimes called creatine phosphokinase. Either one, they're the same enzyme. But creatine, remember, phosphocreatine in the muscle is a reserve, energy reserve to regenerate ATP after you've used the muscle.
all those ones that end in pepsin? Is that like a certain kind of antibiotic?
Yeah, I wish. No,
They all,
they're just all antibiotics, and some that end in mycin are not. So I wish it was the case, but sorry, they're not. They're not. Again, I don't make the news, I just report it. These will all treat methicillin-resistant Staph aureus. That's correct. Yep. So if you've got a patient and they have MRSA, you have options. That's the thing I'm trying to do, is to give you hope. To give you hope. Sydney? Yeah. Bactrim is effective against probably 80% of MRSA strains. Bactrim, you can only give Bactrim orally. There are IV preps of it, but it's not very soluble. So you've got to give tremendous amounts of diluent. You got to pump your patient for a fluid, and they're at risk of hypervolemia. And then sometimes it precipitates out in the kidneys anyway. So most clinicians I know have said, just give it orally. Don't mess with the IV forms. Also, the IV form is a bit of a mess. So most people, just oral. And that is effective against many MRSA strains. Bactrim too is cheap, unlike these drugs that are more expensive. So Bactrim's worth trying. Issue, got a patient with a sulfa allergy though, can't use Bactrim. And what's two drugs in Bactrim? Sulfamethoxazole and trimethoprim. If I had my candy jar from Bible quizzing, I'd let you stick your hand in it. Yeah, Paige? They're used if you have a skin infection that's caused by staphylococci or enterococci. For example, some enterococci are resistant to vancomycin. You would use these other drugs on them. So they can be used for strep as well. Yeah, not just staph. They're also good for strep. They're not good for much else. They don't work against atypicals. They're not good against gram negatives. It's just those skin infecting organisms. Yeah.
So this one we didn't talk about yet, but what is like a normal dose for
Augmented is usually 175 megs of the amoxicillin and 125 megs of the clavulanic acid, BID, usually. Yeah, they're big pills. They're big pills. Yeah, they're horse pills, to be sure. You can cut them. Yeah, you can cut them. They come scored. You can cut them. Do not grind them, but you can cut them. In fact, you can even cut them into fours, and they're fine. Just they're not meant to be ground. But cutting pills like that is completely fine. If a tablet's scored, it usually means should be in your head a sign that says "cut me." If your patient can't swallow horse pills, like the potassium pills, K-Dur, you seen those things? You could choke a meal with those things. Just cut them. Just cut them. Every hospital has pill cutters with a little nurse's trolley with the meds. Just cut them. There's no shame in cutting pills at all. Seriously. Seriously. All right. It's time for a break. So we'll go to oral drugs, and then we'll go from there. We're done with the parenterals. We'll go to orals. 5 minutes. See you then. Morgan. So you're reserved, right? Yeah. Is your season done, or did your season carry over to? Okay. But you guys are still practicing? No?
No, not for now. Maybe later.
Oh, okay.
We know. No, every time, but you need to take all of me to not say. I know. I Yeah, they need help. I didn't even realize that. I thought I was like, great. And then it's like, I was like, I got it. What's about time? I know. What? I didn't know it. Yeah. You know what I did? I was like, that looks familiar. I know. Who's no, I didn't. I was like, oh, so that's there. And then I. Right. There were a couple of them this one. I know. Like, I threw off all I'm like, I don't know. You're like, I was like, I tell the CEO, I'm like,
Okay, gang, let's go ahead and reconvene. I don't know if I said this, but these oxazolidones, these are protein synthesis inhibitors. I don't know if I told you that. Did I? They're protein synthesis inhibitors. They inhibit bacterial protein synthesis. They inhibit initiation of protein synthesis. Grace? That's the way this whole class rolls, right? Yeah, they do. They do, yeah. Fine, ladies, something that is consistent. Streptomycin is a disruptor of the plasma membrane of bacteria. And again, it's too big to get through the outer membrane of gram-negative bacteria. That's why it is a specialist drug for gram-positive bacteria. And cephalosporin, cephalosporins inhibit cell wall synthesis, so I won't belabor that point. Okay. Oral drugs. So there are, first of all, we're going to now talk about oral antibiotics for skin conditions. Okay, so first there are the tetracyclines. How do tetracyclines work? How do they inhibit bacterial growth? No. They inhibit protein synthesis. They inhibit protein synthesis. So this includes, of course, the granddaddy tetracycline, which is virtually never used today. Then there is doxycycline. There's minocycline. There is a very new tetracycline. And that is amatocycline. This is approved by the FDA for skin and skin structure. Infections and community-acquired pneumonia. That drug is very new. Okay, what are the issues? Yes. You don't get it in the hospital. They come in from the community with it. They come in with it. Yeah.
Are there differences, like when you're prescribing it for an infection versus pneumonia, is there, like, is it different dose?
Got that right here. Yeah, same dose.
Same dose.
Same dose. Yeah. Same dose. Same dose. Now, what are the caveats with, what are the adverse effects of tetracyclines? You can have that stuff with any antibiotic. What about, what's more specific to the tetracycline? GI, yeah, GI disruption is an issue. There are extended release forms of these that you can use. They're more expensive, but the GI disruption is much less in extended release forms. So one of the biggies is sensitivity to sunlight. You become much more apt to get sunburned. So you are so increased photosensitivity of the skin. That'd be one of the first ones. Upset stomach. Yeah, Debbie. They're usually a capsule. It's a capsule and you're supposed to swallow it whole. You're not supposed to chew it or undo it and put it on ice cream or something like that. It's capsule that's meant to be swallowed whole. Then you find another drug. These don't come in a liquid form to the best of my knowledge. You can, yeah. There are pediatric versions that are small, that are easier to swallow. You can give them several of those and maybe throw them in applesauce or something like that. That's one possibility. If it's a tube, you can usually break up the capsule and give it to them that way. I can't guarantee the bioavailability in that case, but yeah. So usually some GI disruption as well. The other issue is that, of course, in kids, kids usually younger than 10, you can get teeth and bone disruption. And in women, you can get increased risk of vaginal candidiasis. That'd be the other issue as well. And that goes with the disruption of normal flora that some of you talked about. So these are essentially the things you're going to look out for. Also, you don't take this with calcium or iron supplements. You don't take them with antacids or multivitamins. Those types of ions will bind these drugs and prevent them from being absorbed. So it decreases the bioavailability if you take them with those sorts of things. Emily?
So if it causes bone infection, does that mean that like the calcium?
No, it causes banding of the bone. It gets deposited in the bone, and you get this banding, and those sections of the bone that are banded are weaker than the parts that aren't. It'll do that to your teeth too. It'll stain your teeth, and yeah. Not safe during pregnancy, consequently, because of the effects on bones and teeth and what have you. Yes.
Is there a difference in infection that oral drugs and dental drugs can treat?
If your patient's in the hospital and they're very sick, you go with parenteral drugs usually. If it's an outpatient situation, you go with oral drugs. So if your patient, for example, had surgery, their surgical incision got badly infected, which happens sometimes, you have a skin infection, might be very deep. If they had a knee replacement or something and the incision gets badly infected, if you don't deal with that, it's going to infect the bone and you're going to have osteomyelitis, which is really hard to treat. In cases like that, patients still in the hospital, parenteral drugs are definitely called for. If the patient was fine and they left the hospital, then you can give them oral drugs. If those don't work, then they come back in and they get the big guns, they get parenteral drugs.
So if you were to, if it got so bad, how would you tell it out of an X-ray or?
X-ray will show that quite well. The piece of the bone that's infected is really dark and it looks like it's falling apart. It's got ragged edges to it. Yeah. And drugs don't get to bones very easily. So it's hard to get a good concentration of the drug in the bone. So if you treat them really aggressively, they may still not be able to get the infection clear from the bone. Yep.
If you can't get it out of the bone, do they just have to?
Sometimes, yeah. Yeah. I had a good friend actually who had a knee replacement and he had osteomyelitis and he eventually just had to have a leg amputated. Yeah. So, yeah, stinks. Okay, we good on the tetracyclines? Now, the Oxazolidones, they come in an oral form, and those are given in an outpatient fashion. The parenteral forms are given to people in the hospital. So because we already went over these drugs, I won't read you the riot act on those anymore. So what about these other drugs? Well, one drug that's quite good, particularly if you have an area that is walled off, and you probably have anaerobes in there too, is clindamycin. Sorry? Clindamycin is kind of a drug unto itself, kind of a class more or less unto itself. The beauty of clindamycin is it's very cheap, and it tends to work really well. It will tend to cause some GI disturbance in some people. It may even be pretty severe. So nausea, vomiting, diarrhea is actually not that uncommon. The biggie with clindamycin is that no other drug is more likely to induce Clostridium difficile than clindamycin. So and this causes a necrotizing enteritis. With a necrotizing enteritis, the patient's going to have a lot of blood in their stools, and they'll have tissue that's been sloughed off. The toxins secreted by this organism can really tear up the colon and the rectum and what have you. So if you see blood in the stools of the patient, you want to confirm it with a culture, probably first, but that's, you tell the provider right away, because that's, these can be very severe. These can be dangerous. So that's the other really big thing to watch with clindamycin. Emily?
So what would they, like, why would they use that one specifically? Does it like treat something that the other one can't?
It has a wide spectrum, and it also hits anaerobes. Because it's so effective against anaerobes, if you have a mixed infection, you have something that's been walled over, so you now have anaerobes in there, and or maybe also staph, strep, something like that, but then other anaerobes. Clindamycin is really good for those types of mixed infections. This is oral. But remember, acne, there's a topical form of it too. That's only, topical form is only used for acne. This comes in a generic, soft label, very inexpensive. No, this will also treat gram-negative. This is the widest spectrum of the ones we've looked at so far. Haley? Typically not, because the amount of absorption from the topical form is very small. All right, there's two others that are used for skin infections. And I'm going to erase this here. And the first one you're all very familiar with, and that is Bactrim. This combination, so-called Bactrim, So, and this is a competitive inhibitor of folate synthesis. We make our own folate. We get our folate from our food. Bacteria make their own. So by inhibiting folate synthesis, these organisms cannot use folate, and folate is used to make tetrahydrofolate. And tetrahydrofolate is an important cofactor in the synthesis of nucleotides and also some amino acids. So this prevents the synthesis of DNA and RNA, and also to some extent protein as well. So this is a powerful inhibitor of anabolic metabolism in the bacterium. All right, so these drugs, trimethoprim, sulfamethoxazole, trimethoprim, sulfamethoxazole. These drugs, they're oral. You take them BID. You adjust them for renal function because they're largely excreted by the kidney. Some people will get a rash from this drug. People definitely are more photosensitive. Some people get their skin itches. The biggie, of course, is if there's a sulfur allergy. That's the biggie. And if your patient has a sulfur allergy, their medical record should say so. Because the yogurt, some people, especially if you've taken this for the first time, the sulfur can irritate the GI tract. Yogurt does a good job of coating the GI tract and preventing the sulfur from irritating it also. It kills off some of the normal flora in the GI tract, and yogurt is full of lactic acid bacteria that can repopulate your GI tract. And plus yogurt tastes good. So those are kind of three good reasons. Well, two that are important, one that's just kind of nice to have for taking yogurt when you take this as well. And for skin infections, there's one other drug, and it's kind of new. It's a new fluoroquinolone, and that is called delafloxacin. Delafloxacin. This is a new fluoroquinolone. This is for so-called complicated skin and soft tissue infections. By complicated, it means it's polymicrobial. So this is a specialist against gram-positive bacteria, but also inhibits gram-negative bacteria, very wide spectrum, this drug. It's effective also against MRSA. Yes. About 80 some odd percent of MRSA strains are susceptible to Bactrim. Some are not, but many are. Tetracyclines, MRSA is completely resistant to tetracycline. You don't use those for MRSA. All right, so this one essentially has a lot of your caveats that come with fluoroquinolones. There are lots of side effects for fluoroquinolones. Consequently, the recommendation of the American Medical Association for fluoroquinolones is that you usually use them as a last resort. And also fluoroquinolones, you don't take them with antacids or anything that contains calcium or aluminum or magnesium or something like that. They'll bind to these drugs and prevent them from being absorbed. Of fluoroquinolone, yeah. Yeah, these inhibit topoisomerases. So they interfere with DNA replication and gene expression. Someone's hand was up in the back. Sydney, was it you? No? Andrea, was it you? No? I saw a hand back there. Maybe somebody's just itching their back. Now, a couple of other drugs for bacterial infections of the skin. And have any of you worked in daycare centers? So impetigo is a crusty type infection. It's caused by either a strep or a staphylococcus or streptococcus. It's very contagious. And if one kid gets it in a daycare, usually they all get it. So this will run through daycares. And it makes these crusts that are wet and moist and sticky and kind of icky. And they can be very red. And some kids have them and they don't even know they have them. Others, it looks really erythematous and angry, red and indurated, and the kid's wailing, and it varies, essentially. So there are some good treatments. Some of these are kind of new for impetigo. Okay, who was first? I think Abby was first. Adults tend to not get it. Adults tend to have the normal flora that keeps it at bay. Kids' normal flora is not stable yet. So this tends to be seen in kids. You don't tend to see impetigo in adults unless you have an adult who's been treated with lots of antibiotics or they're immunosuppressed. Then you may see it. Even then, it's not very common at all. Sydney, go ahead. That's a viral infection. That's caused by Coxsackie virus group A, serotype A. Oh, that was your question. Okay, yeah. They can look kind of similar because hand, foot, and mouth looks kind of like your hands have been smacked. That redness that comes from, like somebody wailed on your hand or something. Impetigo, when the crust comes off, can look like that. So they can be confused. Impetigo, you tend to see on the face, usually. 9 times out of 10 it's on the face or on the arms, but usually the face. Okay, the drug of choice usually is mupirocin. And mupirocin is a specialist for these gram-positive bacteria. It is a protein synthesis inhibitor. I think the trade name of this is Bactroban. Bactroban, I think. It's topical. It also comes in a nasal spray for people who have staphylococci that have colonized their nasal cavities. Resistance to this drug is rising. That's why mupirocin is being used less and less. There's a drug that's in the same category as mupirocin. It's called retipamelin. That works the same way as mupirocin. If you get really large lesions, then you may need to treat with oral antibiotics, usually cephalexin or dicloxacillin, usually. Now, there is a relatively new 1% cream for these that doesn't show the problems of resistance that these show, and this is called ozenoxin. That doesn't look right. Yeah, ozenoxacin. The marketed name of this is Zepi. Zepi, that's the name. This is a 1% cream. Very effective against impetigo. Very, very effective. Okay. Those are the antibiotics for skin. And we've got 5 minutes left. Oh boy, oh boy, oh boy. So very quickly, so you remember the penicillins, we talked about these. These are cell wall inhibitors. So you've got your so-called benzyl penicillins. That'd be your penicillin G. Penicillin G is not given orally. There are 2 forms of penicillin G. There is a penicillin G procaine. The penicillin G procaine is administered IM. Except for penicillin V. Penicillin G is not given orally. And there's 2 forms. Don't mix them up. So there's penicillin G procaine that's given IM. Then there's penicillin G benzathine. Benzathine. Where's my chocolate? There it is. Penicillin G benzathine is given IV. And that's a drug of choice for neurosyphilis. Still. Neurosyphilis. Now, here's the thing. So this is benzathine, penicillin. It's called bicillin LA. Los Angeles. Bicillin, Los Angeles, essentially. That's the one you use for syphilis. The one you use for soft tissue infections is called Bicillin CR. This one, you never give this one intravenously. Never, 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 never. Never, never. No. It's the, yeah, this is confusing. It's, they call it, it's called Bicillin CR. It's a benzathine / procaine penicillin. The benzathine penicillin that's injected in an IV port, that's the LA. That's what you use for neurosyphilis. If you use this IV, people have died administering that IV. So never, 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 never administer that IV. Okay. We're out of time. All right, we will finish chapter 7 next time, and then we'll move on to chapter 10. So far as I know, yeah. I already changed it once. If I change it again, people who've done it are gonna have to redo it again. And I don't want to put you guys through that, so just leave it as it is. I already tried to fix it and it didn't quite fix. So way it goes. Okay, gang. That's all for tonight. So good night. Now, see you guys when I see you.
I just had a quick question.
Yeah.
The case studies that are online, do those have specific due dates or is it just whatever we get?
And I forgot to mention that tonight as well.
Oh.